Welcome to this online section. My name is Hao Chen from Joint Santo International Eye Center. Today I would like to share with you a topic on diabetic retinopathy. 56-year-old Mr. Zhang complained of sudden vision loss in the left eye 5 days ago. There was neither pain nor redness in the eyes. He denied a history of diabetes or hypertension. The best corrected visual acuity was 0.5 in the right eye and hand movement in the left eye. The cornea and the anterior chamber were clear with mild cataract in both eyes. The vitreous was clear at the right eye, but there was severe vitreous hemorrhage at the left eye. There were hemorrhage and exudates in the right retina, and the left retina could not be visualized. Finger strip glucose test was 17 micromolar per liter. These are the fundus photos of our patient. On the right eye, there are some red and some yellow spots. The red spots are retinal hemorrhage, and the yellow ones are exudates. On the left eye, there is severe vitreous hemorrhage, and we cannot see the retina. These are the learning objectives for today. First, you are expected to understand the epidemiology of diabetic retinopathy. You should be able to recognize DR from the fundus. Third, you should know how to manage diabetic patients with different grades of DR. Finally, you can list different ways we use to treat DR. As you know, diabetes is a common condition. There are more than 463 million people suffering from diabetes. The prevalence is 9.3%. It means that there is one diabetic patient in every 10 adults. Furthermore, the prevalence of diabetes keeps increasing. Another important issue is that 1 in 2 people living with diabetes don't know that they have diabetes. For example, the patient of our case didn't know he had diabetes, but his blood glucose was so high. Diabetes is not only about controlling the high blood glucose. There are many complications, including macrovascular disorders like heart disease and microvascular problems such as kidney and ocular trends. Among the numerous complications, eye disease is the one most feared in newly diagnosed diabetes, according to a survey. Okay, the next question is how many diabetic patients have retinopathy? Diabetic retinopathy is the third cause of irreversible blindness worldwide, and the leading cause of blindness in the working age group in the United States. Generally, the prevalence of retinopathy increases with the duration of diabetes, but please note that the time of diagnosis is not the time of onset. Half of the diabetic patients don't know they have these conditions. Therefore, diabetic retinopathy may be the first presenting feature in some patients, like our case. Diabetic retinopathy can be graded into non-proliferative diabetic retinopathy, NPDR, and proliferative diabetic retinopathy, PDR. NPDR can be further classified into mild, moderate, and severe. And the clinical manifestations include microaneurysms, intraretinal hemorrhage, venous beddings, edema, heart exudates, and cotton wool spots. The hallmark of PDR is retinal neovascularization with possible complications, including vitreous hemorrhage, fibrous proliferation, tractional retinal detachment, and neovascular glaucoma. A simple fundus photo is enough to diagnose and grade diabetic retinopathy. So this is a normal retina. This is the optic nerve head, and these are the blood vessels, and this is the region of the macula. This fundus photo demonstrates microaneurysms. There are some tiny red spots on the retina. You may miss them if you don't study the photo carefully. It can be easily recognized if you use green channel for reading. It is the earliest sign of diabetic retinopathy on fundus photo. This photo shows several lesions of intraretinal hemorrhage. They are big red spots. Here we also have some microaneurysms. Intraretinal hemorrhage is bigger compared to microaneurysms. Here we can see retinal venous weddings. This refers to the irregular constriction and dilation of venous in the retina. In this photo, we have intraretinal microvascular abnormalities, ERMA. ERMA is also very difficult to pick up on regular fundus photo, but it can be better appreciated on the green channel of the image. These are some shuttle vessels and appear as abnormal branching or dilation of existing blood vessels within the retina. These photos depict hard exudates in yellow. They are lipid exudates from blood vessels. The liquid is absorbed and the lipid remains in the retina. We can also recognize some fluffy white patches, which are Cottonwood spots. They are accumulations of exoplasmic materials in the nerve fiber layer. Retinal neovascularization is the condition where new pathologic vessels originate from the existing retinal veins and extend to the vitreoretinal interface. There are some images with retinal neovascularizations. It is usually found at the optic disc or along retinal veins. We can also see them better in fluorescence angiography, which show hyperfluorescence and leakage. Fluorescence angiography can also reveal regions of non-perfusion, which is hypofluorescence. Retinal neovascularization have several complications which can cause severe vision loss, including preretinal and vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. Macula is a special region of the retina that gives us the most precise vision. Therefore, any disorder involving the macula would impair vision. Macular edema is the leakage of fluid from the blood vessel into the retina. It is hyperfluorescence at late stage, as shown in the fluorescence angiography photo. On optical coherence tomography, the thickness of retina is increased. There are also some cystoid trends in the retina. This is the international classification of diabetic retinopathy. Non-apparent DR means there is no abnormality in the retina. PDR means neovascularization of vitreous or preretinal hemorrhage. NPDR is further classified into mild, moderate, and severe. Mild NPDR has microaneurysm only. Severe NPDR must meet one of the 4-to-1 criteria. More than 20 intraretinal hemorrhage in all 4 quadrants, or venous wedding in 2 quadrants, or ERMA in 1 quadrant. Macular edema is graded independently as non-DME, non-central involved DME, and central involved DME. As we mentioned, there are a vast number of diabetic patients, but the number of eye doctors is limited. However, not all the patients need to see an ophthalmologist. A screening system is critical to pick up patients with moderate NPDR or severe cases. The screening should be based on community or diabetes clinics. Fundus photography is performed. Trained human grader read the photos and decide on referral to an ophthalmologist or follow-up. Recently, artificial intelligence is used in diabetic retinopathy screening program to save human effort in image reading. The treatment of diabetic retinopathy includes laser, surgery, and intravitreal injection. The mechanism of laser photocoagulation is to destroy the cells at non-perfused region, which secretes vascular endothelial growth factor (VEGF) to reduce retinal neovascularization and leakage. Another treatment is intravitreal injection. It is a simple procedure. This is a video of intravitreal injection. The drug we use include corticosteroid and anti-VEGF agents. Surgery is indicated in proliferated diabetic retinopathy. It can remove vitreous hemorrhage and treat retinal detachment. The management of diabetic retinopathy depends on the grade of the ocular trends. Diabetic patients without retinopathy should be followed up at 1 to 2 years. Mild NPDR should be seen at 1 year. Moderate NPDR should return at 6 months. Severe NPDR should receive laser or follow-up in less than 3 months. Patients with PDR should be treated with laser or surgery, while those with macular edema should have intravitreal injection or laser. Finally, let's review the learning objective of this section. About 30% of diabetic patients have retinopathy, and the prevalence increases with time from onset. Diabetic retinopathy can be graded into mild, moderate, severe NPDR and PDR. Some patients may also have macular edema. The grading is based on fundus photo. The treatment approach of DR includes laser, surgery, and intravitreal injection of drugs. Management of the patient should depend on the grades of ocular pathology. Non-DR, mild NPDR, moderate NPDR can be followed up. PDR and macular edema should be treated. Severe NPDR should be closely followed or dealt by laser. Thank you for joining us. These are some references for further reading.